Coming up on Live Well.
Okay.
in your record.
At any time during your life?
At any time during your life, you can go in and request, you put in a release for information.
Right.
I've kept the promise. Primary, you can go to.
Brought to you by Mom Well Care Kit. Wrestling one mommy at a time. You should get yours today.
Hello, welcome back to Live Well. You're with Marcello, Thedford. I'm with my co-host and my wife, Trina McGee, right now. So we have some interesting things. And again, first, welcome to Live Well, where we tell you we're about good, healthy talk, okay? Forgive me, I'm a little excited today because I have a really cool guest and everything. And she is a health care professional hailing from New York. Her name is Ayana Culley. Ayana Culley, welcome to Live Well.
Thank you.
you.
Thank you for having me.
No, it's really great. Trina told me about you. I don't know everything about you, and I know you guys had just recently met and everything, but you are a little bit of an insider to the health industry of what's going on. You've seen some things, so just say it like that.
I have seen some things. I've been in there for a while.
Okay, so tell us a little about yourself. Tell us what brought you into the industry, and tell us all that you know in the sense of what you have done in the industry.
All right. So I've been in healthcare for about a little over 20 years or so, in various roles. Started off in just administrative work, went into health information management, which is a broad area that kind of handles quality management, coding, billing, auditing. It's a big range.
Right.
Release of information, like if you need your medical records. It's really, everybody knows of it as medical records.
Medical records.
Yeah. So, and then I went on, I became a nurse.
Oh.
And I worked as a nurse for some years in specifically home health care, seeing the geriatric population, hospice, palliative, and some post-acute care, where they had they needed wound care and things like that.
Okay. So home health care, you were going into houses.
I was going into houses.
Okay, and hospice, those are people that are terminally ill.
Terminally ill, correct. Need support. Their families with themselves have decided that they would like to terminate active treatment.
Oh, wow.
You still receive treatment in terms for pain, for comfort, just to make you comfortable as you transition. Typically, unfortunately, a lot of people make that decision a little late. The average was within 3 days, someone would pass, but you actually have hospice care for with your insurance for 6 months.
Okay.
Typically.
Okay. But you said people usually don't live out that 6 months.
They don't because they decide later.
Who wants to accept that reality?
Exactly.
Yeah.
It's difficult. It's a difficult, who's to say when is the right time to move into more of a palliative care. And palliative care actually spans the lifetime. So we're taught as nurses that palliative care is actually more about comfortability. Anything that would make your care, even if it's just you went in for your appendix removal, if it would make you more comfortable to have maybe certain music or having maybe dog therapy or anything around making your care more comfortable, that's palliative care. And palliative care, sometimes people hear the two together and they think, oh, well, they're gonna die. So that's not necessarily true. Palliative care is from the time that you're ever admitted to the hospital, you can talk about how to make your stay more comfortable, or even if it's outpatient, whatever your healthcare needs are. So, so all my patients were in the hospital. I'm sorry, at the home. And then eventually I transitioned back into, actually I never left health information management, but I went more into a more senior role in health information management.
Tell us more about health information management. What this all in?
So it's like I said, it's a broad area.
Right.
It used to be, called medical record librarians, like in the 70s, and really that part of it manages the health record. So this is one thing I like to tell people. the person owns the information, the hospital holds the record. So you are always entitled to your information in your record.
At any time during your life?
At any time during your life, you can go in and request, you put in a release for information, but it's supposed to, you can get it at any time. Sometimes it's a process. I'm not going to say that just any person can just print it out and give it to you, but there's usually you would go to the Health Information Management Department, or sometimes in some places still called Medical Records Department.
Do those records stay there for the duration of
Of your life?
No. So the law is, I would say it in two different ways. The law is usually 7 years after, for an adult, they are legally required to keep it for 7 years after the date of discharge. So as you know, you might go in multiple times. Each one of those have a separate date, right? For children, it's the age of majority plus 7 years. So some states is 18, some states is 21 plus 7. So children should be there the entire life.
Yeah.
And that's the entire record. Whether it's, radiology, lab work, strips from your fetal monitoring, all of that should be kept.
Okay.
Whereas
you go to different hospitals. So if I went to a hospital 3 years ago, I go back to that particular hospital to get that health management records.
Correct. And also your doctor's office, they're supposed to keep your records for 7 years too. So your doctor's office, any person or a provider that's keeping records on you, they're supposed to keep it for 7 years. You can request, I want to say this about requesting your medical record. You can request your medical record. There is going to be a specific authorization that you have to give for psychiatric records and for anything related to HIV.
Right.
Doesn't mean that you can't get it. You can still get it, but there's a special request because also remember, you're not the only one that's entitled to the information in your record. Your insurance companies and sometimes legal entities might be able to request, yes, so they can put it in a request. And they don't automatically get the psychiatric and HIV status because of the stigma. This happened in the 90s. The stigma behind it. Psychiatric is more about if there's anything that could potentially harm the individual, you would have to have a doctor, usually the psychiatrist, that would sit with them to maybe explain anything that needs to be explained.
Okay.
But you're still entitled. It's all you own the information.
You own the information, the records.
Yes.
Okay.
So that's one part of the HIM world.
Okay. The him world.
The him world, yes.
What about the her world?
Well, man.
I wish. Oh, the name world. That's one part, the release of information. But then there's other parts in terms of billing, coding, quality. They say quality management now, but there's a lot of quality reporting statistics. Coding sort of falls into that because every diagnosis that someone has, every procedure that someone has, there is a code attached to that.
Really? Okay.
Yes, and the codes come from the World Health Organization.
Oh, I didn't know that.
They produce the codes. Every country can do a modification. So the U.S.'s modification is it's International Classification of Diseases. That's the full name.
International Classification of Diseases. Okay.
We're in the 10th edition right now. 10th edition. .cm, which is clinical modification. That's the two-digit symbol for the U.S. Like it's .ca for Canada. All the countries have their own little modification, and that's for so that they can modify it for their location for like tropical diseases. If there's a place that has certain types of diseases, or
So are you saying that the government also has access to if the government wanted to go into your medical records because if they were studying, I don't know, tropical diseases, they actually really can do that. They have access to your information.
They do have access. It's supposed to be anonymized, right? So, but that's how we know that the percentage of cancer in this country is different than the percentage of cancer in another country. that international classification of diseases allows for that information for all the countries to be able to put in and do a comparison where we can see that, maybe gastric cancer is on an uptick here or whatever it is.
Yeah.
It's also how we do a lot of research, having those codes. Now, the way it's supposed to be done is an IRB process, which is International Review Board. If any researcher that wants to do research should be putting in a request through, there's many international review boards, whether it's you're doing a research for your hospital or maybe your university or something like that, a think tank or something like that. There's a process they have to go through.
Okay.
It needs to be anonymized. You have to only get specific information. So they shouldn't really get all of your record. You may just want records from people that are 18 to 25 that have a diagnosis of X. And you can just get that piece. They really shouldn't have your whole record. But I do want to make a statement about insurance companies getting your information. If it's your insurance company,
Yeah.
they have access to your record.
Oh, okay.
They have
Because-
access to your record.
Yeah, so I don't know if you ever go in and you sign.
Very.
Well, this is when you sign those forms and they say for payment, if they're paying, and also for treatment, is for billing and for treatment. I'm sure there's some other words I can't think of right now, but for billing and treatment, your other healthcare providers might need it. Because when you go into the hospital, it's not just you. It's not just your primary care doctor. There's nurses, there's other doctors that's covering their shift. There's medical students, all of them. So it's sort of like a blanket authorization for people that are treating you should be seeing it. When I say treating you, it's because your friend that is a receptionist that works, in the floor above should not have access to your record. That is absolutely no. That is, and they do get fired for that. You should not. I don't know if you ever hear of celebrities they go in.
I was just gonna say.
Yeah, they get fired.
That happens a lot. There's a particular hospital in LA that has happened a lot.
Yeah.
UCLA.
Not saying no name.
That's that menu. We know what hospital it is.
Yes. Well, they got, sometimes the money is, that's another topic, but the money is more than what they're probably getting paid. So whoever paid them for the information, I mean, some people like to do it for clout, but
Well, let me see this. Let's dial back a little bit. Are you kind of saying, inadvertently saying that hospitals in the United States are held to a World Health Organization standard to some degree?
so I wouldn't say that they are held to a standard by the World Health Organization, but there is the Health and Human Services Administration,
Okay.
which, okay. It's like I could go somewhere with this, but there's the Health and Human Services Administration, which covers the CDC, which we all know about from COVID time, Center for Disease Control, CMS, which is the Center for Medicaid, and Medicare and Medicare Services.
Okay.
There's the FDA that falls under the HHS.
Okay.
There is.
I didn't know the HHS. This is great news. I did not know they were so powerful. I had no idea. You never really hear about the HHS. You hear about the FDA separate. You hear about the CDC, but I did not know they kind of had.
Yes. There's a little.
Hear about it.
And I mean, these
Other
right, and those separate organizations have their own rules and regulations that people need to abide by.
Right.
The World Health Organization is there. I wouldn't classify it as that they have any sort of control, but they do collect information. They do information exchange, and they might put out goals. For instance, one goal that I would say practitioners at the lower level may not know about is healthy people. There's the World Health Organization does something called Healthy People. I think we're on 2030 right now, but they did one 2020, 2010. And it's sort of like all of the countries have decided these are our goals that we would like to eradicate sexually transmitted diseases.
Right.
We would like to lower the infant mortality rate. We would like to, have more people insured. Yeah, so they will come out with sort of like a broad,
Right. Of a goal they're going to hit by 2030.
Right,
In fact, you
yeah.
heard about this. Yeah.
healthy people turn. Yeah, so we haven't met a goal yet, but
None of that sounds eradicated.
I don't think so. I don't think we met a goal yet, but it is good. We always have to have something to work towards. So, chronic diseases, diabetes, things like that, cancer, so they'll come up with goals. So the World Health Organization would,
Comes up with these goals.
and they do information sharing.
They get a lot of money to do that because if
There's
there's
also-
eradicated, I'm kind of
Good question. I don't know how that works at that level, so I don't want to misspeak.
yeah.
If I don't know if all of the countries are putting in funds. I'm not exactly sure how that part of it works.
Yeah.
From the nursing perspective, I'm familiar with the healthy people goals because we try to educate around that. When I was in school, I did some fundraising around malaria and dengue and trying to lower those, collecting for nets. Just the simple nets, can help educating people about not having standing water. So you can do initiatives around some of those goals. Yeah. So I'm not sure how the money part works, but the countries sort of buy into it. Yeah.
Okay. Well, let me know. Explain to me more about what's happening on the ground in the States. Let's lower it, narrowing it down from the World Health Organization.
Yeah.
Just to our local hospital.
Down to me and you.
Exactly, me and you. We know that people have health insurance. People, some people have copays. Some people have different setups in their copays. Are we getting healthier? Is America really getting the medical treatment it deserves?
Is there a business in being sick?
Yes.
Wow. Just I heard you say.
I did.
Is there a business in being sick?
Yes.
Wow. Okay.
Okay, so that is a very big question, and there's a lot of moving parts to it. The insurance industry and pharmaceutical industry are very big, and they lobby for what they want. But you also have the Medicare insurance, Medicaid insurance, what the majority of people are on.
Right.
And that is by under CMS, one of those entities that I said was under the HHS.
Right.
And in terms of at the local level for the hospitals, they do not, the majority of people are on Medicare and Medicaid, whether it's or the ACA, which is the Affordable Care Act, which is similar to Medicaid.
Okay.
And that Medicaid is administered by the state. So the funds are used by the state, but it's all coming from up top. But the funds are administered by the state, and Medicare is federal level. And they are not getting reimbursed at the level that they need. Care is getting expensive. These new treatments and new procedures are expensive.
Yeah.
And you have the population that's on Medicaid, also Medicare. I mean, the fastest growing population is the over 65 group, right? So they're not getting reimbursed at a rate that's necessary to continue to provide the services and care that they need. They have been, advocating for increases in reimbursement. The hospitals, are advocating for increases. But from my point of view, it seems as though they keep chipping away, meaning the insurance companies are chipping away at what they cover, how much they want to reimburse these hospitals, and they're increasing co-pays, and increasing the deductible that you have to meet.
Right.
I think the system needs reforming.
Yeah.
Right.
From top to bottom.
I totally agree.
Why America has some of the biggest medical bills in the world. I mean, it's ridiculous.
It's insane.
There was a procedure I saw that I wanted to get, a woman procedure, and it was like $8,000 in America, and then
And overseas.
overseas it's like $300. So
Wow,
that-
the difference in price there.
that's big.
And there's a lot of medical tourism like that. And there's a lot of very qualified providers across overseas.
Yeah.
Whether it's dental, whether it's cosmetic,
Yeah.
whether there's just for general care. I just saw somebody's TikTok where she went to it was Turkey.
I was gonna say Turkey. I don't
One
know about the turkey thing though.
No, but listen, there's plenty. You have to do your research like anything, right? And I would tell people to do research even in the U.S.
Right, because you have some doctors here that
Exactly.
saying.
So, but there are plenty of qualified individuals outside of the country. And a lot of times, some of them are trained in the U.S., but for various reasons, they go back either to their home country or they go to someplace where there's a better cost of living. And so they're U.S. trained, U.S. licensed, but they went for, other reasons. So there's a lot of reasons. To your question, though, it's multifactorial. Some of those, the cost of living, right, is different. Some countries pay for your medical school, so they don't have that medical school debt that a lot of providers have. So when they have to charge high because they got to pay that mortgage payment of a student loan bill, right? There's that. We also are a litigious society, and I believe some of it is warranted, but there's the people that are opportunistic. And that bogs down the industry. So your insurance rates are higher because they're afraid that they're going to get sued for something. That's why we have decreasing OBGYNs, because the malpractice insurance is astronomical.
Wow.
Malpractice insurance, some countries, they didn't even have it because they don't expect to be sued.
Yeah. America sues.
Yeah, it's nice because you said a lot right there, and I just want to pick at it a little bit.
Sure.
Why is our insurance bill so high? Well, who sets the prices? Is this hospital? I don't think the everyday person knows who to blame for this at the end of the day. The hospitals are charging me too much. Is the insurance company doing this? Is it at a higher level than them? I mean, what's the squeeze on the regular taxpayer?
So that's also part of it is what I just said, the litigious aspect of it, being sued a lot.
Okay.
I can't say that I have all the answers, but I can say some elements of that is the suing of it. The others is the enormous red tape that these are not public companies. These are for-profit agencies.
Right. They're not doing this because they love sick people.
That's what people
Correct.
really know.
Right.
Right.
These are for-profit agencies. For the most part, they're supposed to be doing a public good, but
they're in it for profit.
they're in it for profit. And they create barriers and they create red tape. And I could just tell you from the auditing experience piece of it in terms of coding and billing, and where I see is going to get worse. But these codes that I had mentioned earlier are used for billing. And so they put them on the bill and then submit it to the insurance company. And that's how the hospital will get reimbursed.
Okay.
There are a lot of rules, whether the hospital signed an agreement, whether the provider signed an agreement about how they're going to treat someone, or what they're going to have included in a sort of a global payment is what they call it. So that you're not picking and choosing and trying to nickel and dime the insurance company either, right? Because they're going to say, well, you knew the person was coming. So that bed that they were going to spend the night, they had the procedure, and that procedure normally takes 2 to 3 days of recovery. So that should be all one. Don't try to charge me for this day, and then try to extend their stay and something wrong with them so you could charge me some extra days. Then, they don't like that, which is good resource management, right? So they have rules for that. What's happening, though, is through clerical error, or it might not even be an error, it's getting to the insurance company and they are denying the payment for whatever reason. Maybe
I've heard that before.
Right.
I've heard that, and
So what do you do?
hurts the family
Yeah.
or the person.
it is terrible. So that part of it is what causes a lot of increase in the money that's around how this is administered, right? Because now it's denied. The hospital is like, no, this should be paid. They have to pay somebody like me, or they have hired their staff to re-review. So now you already reviewed it. You already put what you think is the right code on. Now we've got to re-review and make sure, did we do the right thing? Yes. Did we follow the rules? Yes. So we submit it to them again. Write an appeal letter. This is taking time and resources, right, from the hospital, the staff. So now they've already dwindled down what they were supposed to get.
Oh,
we were supposed to
charging you for all that? I mean,
no, you're paying for this to be able to correct whatever the error is.
so you have to pay the admin.
You have to pay the administration, the hospital. That the hospital pays the administration.
So obviously, no one's in great spirits when they're going through this process, you know, because they're dealing with a pain of a family member that's going through some medical condition. Or
Well, that's the other half, right? Because that's one half is the hospital trying to get their payment. Meanwhile, the hospital is sending you a bill saying your insurance company denied me, so now you owe me the $10,000.
Right.
And everybody's trying to fight to everybody's trying to figure out who owns what. Did I do the right thing? Is this something that my insurance didn't cover? Because that's another piece of it. Your insurance may not cover the thing that you want.
Right.
So did you not look at it? And whose fault is that? Was the hospital supposed to check that before they actually booked you for this procedure?
Right.
You know, there's multiple layers, and all of those layers cost money.
Right.
And that also comes back into that industry of why everything costs more. But the main point is that it's a for-profit industry.
You know, I learned that firsthand. Little story, my wife knows. Back in early 2000, I was doing a movie. I was shooting a movie. I was starring in it, and actors have to get physicals. So I had to get a physical. So I went to see my doctor in Los Angeles. When I got the physical, I was coughing a little bit. So he said, you know what, I don't like that cough you got. So I coughed a little more, and there was little spots of red. It's like spots of blood. He said, you know what, we need to get you checked out real quick. And come to find out, I had a DVT, which is a deep vein thrombosis. You know, I had deep vein issues. I had blood clots in my rear leg and everything. I would say from meeting that doctor to about less than 90 minutes later, I was in ICU.
Yeah.
I was in intensive care, and they had everything connected to my body. I had my kids there. I was possibly going to die, you know, and we had to have immediate surgery. Okay. That one surgery took my life in a whole different direction. I come from action movies. I come from starring in TV and everything. And now Mr. Superman is laying there in the bed and I can't even move for a minute. And that's when I got a first taste of the medical industry, you know, and I thought things were being done for care. But then when I started going into aftercare and certain things to rehabilitate myself, unfortunately, my insurance didn't cover a lot of different things.
Yeah.
And I was left to fend for myself. And I'm bandaged up. I'm sutures. My wife is redoing the dress wounds herself. I think I left there after surgery with some gauze and some prescriptions.
And
Yeah, and they just pushed me out the door. No type of helping me out and anything. And unfortunately, that led to another surgery and another surgery. Since then, I've had about 7 surgeries on my legs. You know, since this happened in 2000. And
hey, moms and moms to be. This is Trina McGee, and I'm so super excited to tell you about a great, amazing opportunity. Well, first of all, have you ever just dreamed that someone would just send you a package just out of the blue because you're the mom and you want to feel loved? A package about you, about your wellness, about your journey as a mom or a mom to be. Well, that wish is about to come true with the Mom Well Care Kit. Girl, you better grab that phone, grab that laptop, that tablet, whatever you've got, and head on over to the website. That is your way to get the personalized care that you need. What are you waiting for? Just sign and click on the link below. It's all there for you, the Mom Well Care Kit, waiting to be sent to you, waiting to pamper you. Remember, you're the mom. You're the heartbeat of the family, and everybody needs you. So take care of yourself. Thanks. From me and from Momwell, Trina McGee here.
I've racked up medical bills. I've went with other insurance. It's people didn't want to pay out. I find myself being more on the phone dealing with insurance companies than anything else. But the stress level is insane. I mean, it puts your family, it puts you through so much at the end of the day. With my wife through so much, tears.
Makes you hopeless.
It makes you hopeless,
Yeah.
you know, and it makes you feel like an invalid. And I remember the answer was a lot of painkillers, you know, which I had to wean myself off of after a while, because what I look like as raising kids and their father is drooling or you know, talking with a slur, or you can't remember nothing. And I told my wife, I just can't do this no more, you know, at the end of the day. So I just think it encompasses a lot. It brings in a lot of depression, you know, when you want to be taken care of, especially in it's called insurance for a reason, but not for the reason that you think, you know? You know, they're more of they never lose the case. Right, insurance for them, they never lose, but you possibly lose. You have you had instances of that with people that have been through things like that in situations?
Yes, especially for home care, because that was the area that was in. So there's a lot there. So I think we need a lot of work. Well, as I said, we need insurance reform. That's one. But also I think we need to introduce the health advocacy role, a family advocate, not necessarily for the hospital, because sometimes they have a health advocate in the hospital.
Right.
But you need that post-discharge. You need someone that can help you navigate. Another term for them is a health navigator that I've heard used. I think that industry needs to grow a little bit more. The problem with it is, who's going to pay for it? You're already sick. Your insurance company is not paying for what they're supposed to pay. The hospital is calling you for the bills. The debt collector's calling you.
Right.
Can't work.
There has to be some place somewhere that, and whether it's the insurance company should allocate a portion of their revenue to hiring. But you know, why would they want to help themselves? Why would they want to help people help them take money from them? You know, so. But somebody needs to figure out a way to help people navigate the insurance industry. And much like financial literacy, we need to talk more about health literacy, and not just in the part of care and wellness and preventative measures, but also in navigating the health insurance industry.
So I totally agree with you, Rachel. Well, quick question, and you know, and I'm not just for the viewers at home too, our Live Well viewers. Why is there no price transparency? If it's for profit, okay, and just like a McDonald's or anything, it's for profit. You know, you're not making burgers because you love feeding people. You're making burgers because you're selling them. Well, no disrespect to McDonald's. But what I am saying to you is, why is there not a menu up there? Why is it? Oh, heart surgery.
Yeah, why don't they tell you when you go in? Yeah, why don't they tell you when you go in, or they have a list: heart surgery, $3,500, you know, injection, $10, or whatever it is. It's like, why? It's a surprise at the end of being sick.
Yeah, you know, you're surprised. Yeah, sick. You're surprised. You gotta go to the hospital. So now I gotta be surprised about what I'm getting paid, what I have to pay.
Which is gonna make you sicker.
You sicker. That can't be healthy. That can't be healthy at the end of that day.
I think that's probably intentional. I think, like I said, they negotiate rates with the different insurance companies. I will say that anyone that receives a bill from a hospital that potentially has to pay it because, you know, maybe the insurance company is not going to pay something, scrutinize your bill. There's too many times where they added on an extra IV line or some fluid that you didn't receive. Maybe they ordered a medication or a test that you refused, or they didn't take it off.
That real expensive medicine.
Right.
Yeah.
Yeah, I mean, the expensive ones, they keep track. But because they keep track of those.
Yeah.
But the other little ones add up.
Right.
Right. So You want to make sure, I mean, anything could be on there.
So
So
every time they change the IV, they come in your room, that nice nurse that says,
Yeah.
"Oh, we're here to change your IV. You know, we switch it." You're paying for that.
That was free.
well, well, if you're gonna, it's included in that global payment
Okay.
that I talked about. If the insurance company is gonna pay for a procedure or for a stay,
Right.
it will be included in there. Will not be itemized.
Yeah.
But if you have to pay,
Mm-hmm.
it will be itemized.
It will be itemized.
It will be itemized. Now, I don't want to hop on nurse instead of nurse. If we're changing an IV line, it's because we have to. Either the drug has to, it has to be changed for a number of reasons. But it doesn't mean that there are not extra ones that got on there by accident. Tests, like I said, medications that may have been ordered, but you refuse it, like a pain medication. You're like, oh no, I don't. I'm good. I don't want that. That could be on there.
Right.
Yeah, because it didn't come
It's
off.
like a restaurant. It's like going to a restaurant. You order this, you order chicken nuggets, you order the cheese sticks, you order dessert, and you order the menu. And you're like, wait a minute, I didn't order this. But I mean, ask you, in all reality, how many people really scrutinize their bill?
Not a lot. Not a lot.
Because you're sick.
People are overwhelmed with the payment aspect of it that they don't look for. But another thing I would say, beyond scrutinizing the bill, you can work with the hospitals. Sometimes you can negotiate it down. You act like an insurance company. They negotiate their rate. They this is what. Yeah, you can negotiate.
Why?
Yeah.
You can say, hey man, I want to pay cash.
You would love that.
I mean, if I buy this now, you give me a good deal on it.
You can negotiate. You could negotiate. But they have sometimes the social worker or somebody that might assist and will say, okay, well, depending on how large this bill is, right? So, and if you have insurance, you don't have insurance, that's a big thing. They might be able to get you emergency Medicaid that might be able to take care of some of the bill. So just don't take it at face value. Yeah, really scrutinize it. Call them and say, can we work something out? I can't afford this. And go from there. Yeah. There might be other options for you.
What is considered the most better insurance setup? I mean, I've heard of, and forgive me, I've heard of PPOs. I've heard of different things. Well, what exactly, when someone comes in like, oh, that person is golden. There's gonna be
I don't like that when you come in and they assess you through your insurance. It's just awful. I had it happen to a cousin.
Yeah.
She came into the hospital. She didn't have insurance. She had a foot infection. They sent her back, came back again, sent her back. Next thing you know, they were cutting off half her leg because they hadn't just treated her. All because she didn't look like money.
Yeah.
And this is recent. This happened.
This is very
We won't
recent.
name the hospital, but I believe this happened in Las Vegas.
This happened in Las Vegas.
Yeah, it's Zouder. It's happened in Las Vegas, Nevada recently.
I'm sorry that happened. Unfortunately, if it's emergency, and it also depends on the type of care. Now, they're not supposed to do that. If it's emergency care, there's a law that they're supposed to emergency care is supposed to be taken care of. But once they get you to the point that the emergency is over,
Right.
they can transfer you to another hospital.
Yep.
They can, say, well, time for you to go home, whatever the case is. I can't, to answer your question about which insurance is better, paying cash is the best way.
Wow.
But
Wow.
I can't say which insurance company is better because they all offer different levels of insurance.
Okay.
And it could be different based on the state that you're in. And it could be different based on your employer. Yeah, if you're getting insurance through your employer, it's what your employer had negotiated with the insurer, or what was offered to them even. Because when they do insurance for the employer, what they do, and this is probably for smaller businesses, but I'm sure they do it for larger businesses too. They look at the profile of your workforce.
Okay.
So you have 18 to 65-year-olds.
Right.
The majority of them are over 50. That means higher price. They're going to be on more medications. They're going to, whatever the case is. Yeah, and they do a risk factor score.
Correct.
And they decide what they're going to offer your employer for insurance that they can then pass on to their employees. And the employer has to decide which one of these they want to pay for, right?
But is that really fair at the end of the day? That because, okay, let's just use a hypothetical that okay, this particular business has a risk factor because it has a lot of people over 55 and above, right? So what happens to the ones that work in the mailroom or wherever and they're 24, 25? They get lumped up into that situation paying the higher premium?
Yeah, they'll get lumped into, well, so depending on how large the organization is that they work for, they might have multiple tiers that they could offer,
Okay.
right? And each tier is going to have a different payment that the employee has to pay in.
Okay.
Sometimes the smaller the organization is, they'll have less options available to them that the insurance company is offering them. Some insurance companies, I mean, they'll offer you nice insurance, but it will be cost prohibitive for a small business. You know, I mean, some of these insurance for a business could be $20,000 that if your employer is saying somebody that's paying for your insurance, that's an additional $20,000 on top of your salary that they are paying. You're not seeing it,
Right.
but it's in your insurance. So all of these insurance companies have different tiers. Sometimes it's sort of out of the control of the employer if you're getting employer-based insurance, because it's whatever the insurance company is offering them and what they could afford. You know, insurance companies are going to try to give you the best that they can at the price point that they can afford. I'm sure they all want to give you the best, but that's just not a reality. I can't say that one insurance company is better than the other. Now, you did mention something about PPO and EPO. So PPO is usually the type of insurance where you can see any doctor. It's out of network, in network. It's basically the two terms. And the out of network is going to cost more. And the in network is going to cost less. Depending on the city or state that you're living in, that's going to either limit your options or expand your options. In New York City, where we live, we have a lot of in-network providers, so we have that option. But a smaller town, city are going to have limited options in terms of what's in-network for them. So that's the kind of the difference with that.
Do prices also change per state? Are some states higher than others that you live in? What would you say is the highest state of
Probably New York and California.
New York and California?
It's like they're just making up numbers. You know, well, every price is a made up number. But it seems like, to some degree. But I'm saying, what is the overhead really being made after they've just done the work, the healthcare work? But I think the overhead, the profit just seems like astronomical at this point.
Oh yeah, I don't have the exact numbers, but I could have sworn that when the numbers came out, that some of these pharmaceutical insurance companies made billions in profit. I don't have the exact numbers, but they're not losing money.
Right.
So yeah, it's difficult terrain, and that's why I think we need comprehensive reform in the health insurance company. But as you mentioned earlier, the pharmaceuticals and the insurance lobby are very powerful people. And not to make this political, but it is healthcare related. The president-elect has stated that he wants to have RFK Jr. No, he's not junior. Is he a junior?
RFK.
In charge of HHS, which is that high tier one. And he wants to eliminate and cut a lot of things. Cut out departments within the FDA, which is the ones that test medications to ensure that they're safe for the masses. And not to say any medication is 100% safe, but they do testing to get it to a level that they feel right
Before we put it in people's bodies.
Right. You know, CMS was gutted under his last administration, meaning that he fired a lot of people. That also causes a lot of red tape, a lot of slowdown. These hospitals not getting their reimbursements in time for them to, because you need those reimbursements to keep providing salaries for your staff, to purchase the medications, to then give it to the patients. So there's a lot that goes into it, and you know, unfortunately, at this point in time, I don't see it getting better. Given where we're going.
Okay.
You know, people have to really start focusing on preventative care. This is the time to go see your doctors now. Go get that full checkup.
Right.
Unfortunately, medical tourism is not available to everyone.
Yeah.
But get what you can get. Go to your doctors, get all your testing done. Don't wait for your colonoscopy. Get your breast exams done. Get your mammographies done. Pap smear, where everything needs to be done, and
Start from being sick. Be aware.
be aware. I think things are gonna take an interesting turn, and
Yeah.
there's a business of being sick, and I think
That's what I was going to ask you real quick. With all that, when they see you in the hospital, are the big, is Big Brother, the elites, are they looking at you like a price tag? It's like, is somebody in there worth it? Like they hear, like I have DVTs. I've had blood clots in my leg, like I said before. Do they say, oh, that's $100,000 easy, or that's $500,000?
no, I don't think so.
To some degree.
That's
'Cause they have to
hard.
engage.
Yeah, no, I don't think provider. Listen, there are some surgeons and cosmetic surgery that's like a different category, because a lot of insurance companies don't even pay for cosmetic surgery, so they might be looking at you as a price because it's cash coming to them, right? But I think generally, people in healthcare want to help people, right? Whether it's a doctor, and bedside manner is a different thing. And and stress levels is a different thing. And being underpaid can contribute to maybe how people behave. But generally, people want to help people. And I don't think they look at people as price tags per se. No. Surgeons, they do like to do surgery. So if you are you were recommended to have a consult with a surgeon. A surgeon wants to do surgery.
They push surgery
a
a lot.
you do have some good advice.
Both of us, but yeah.
Yeah, they push surgery on my wife pushing to have me have surgery. A couple times
A couple times.
I think
We all.
we opted out. The first couple times we were scared. We had to. I mean, that's a lot. I'm not a medical professional.
I went into a hospital once and I had a very bad ear infection, and they, for some reason, thought they needed to do a biopsy and go up my nose and take a piece of my brain. So I'm like, but my husband was like, no, we're not going to do that. We didn't. But they really do.
I mean, that could have got really, really bad.
And expensive or unnecessary. And
Yeah, I had to learn about biopsy. And once I learned,
What that was.
and how that could be. I mean, it's a possibility you might not be the same afterwards, or you might, it could possibly cut down your longevity of life to some degree, unfortunately.
I mean, it depends on surgery. I mean, sometimes biopsies are very helpful. Biopsies can be helpful, but there's certainly questions as the patient, the consumer, that you can ask. What are some non-surgical ways that we can try this before, right? Surgery is necessary in certain instances, but there's a lot that happens before that, right? So you can try non-medicinal therapies. You can do physical therapy. There's other modalities that you could try before, and you could say, like, okay, what's my timeline here?
Yeah.
Right?
Yeah.
And sometimes you have to assess that for yourself, because sometimes the pain is just so bad that you just cannot focus on anything else. And
That's why it's good to catch things early.
It is.
So you don't get to that point.
Do you believe in natural remedies?
I do. I believe in natural remedies, but I shouldn't say that they have a lifespan, but you have to do them early.
Yeah.
You have to be consistent.
That's what I was going to say too.
And the problem with us in the U.S. healthcare system is that we don't know enough about it. There are some, it is a shame, but they like to stay up on indigenous.
I mean, they're making money, the old saying, if it ain't broke, don't fix it. I mean, you just be adding more people to the pie. I mean, it's working for them the way it is right now. It's that system I like. Yeah. The big companies.
Right, they don't want to fix it. They don't want to fix it. And they've also a lot of medication comes from natural remedies.
Exactly.
Listen, all those things are in the plant, in the forest. Exactly. They may have found a way to concentrate it. They may have found a way to mass produce it. they may have found a way to make it synthetic so that they don't have to use as much the natural resource as possible.
Correct.
But a lot of it comes from the earth.
I mean, how did people get along before we had all these Western
Right.
medications and hospitals? I believe people were much more in tune with their body, and they could say, "Oh, I have this little thing. Let me go get this plant," but they would feel it early on.
Right.
I think there's so many things now polluting our bodies that we're just not aware of really what's going on, or we feel something, we just, I got to go to work. I'm not going to worry about it. It's nothing. And everything happening with your body is something.
Yes, I agree. And that is very important to know. Don't let a provider, when you go in and they say, oh, it's nothing. If you feel like it's something, it's something.
Yeah.
Right.
A lot of Black women are complaining about that.
Oh, that's
That's a whole nother.
That's a whole other thing.
And basically, stories I've heard, but we can always do that for another
But
day.
I do want to just add one thing to you. You asked about the natural remedies. We do have examples out there of mixing, and I believe in natural, but I do think that there's a way for there's a balance for both, right? And one way I like to describe it, when I was in nursing school, Costa Rica, they have an indigenous population, and they stay up in the mountains, and they take care of themselves, and they're actually, antibiotic naive, meaning they've never even had an antibiotic or a vaccine or anything like that. But if you break your leg, you need surgery. You need a way to fix that.
You can't just tie it to a stick.
You can, and it depends on how it break. Depends on how it's broken, right? So there are sometimes you have to veer into a more I would call that non-traditional or a hospital setting, right? But Australia and Costa Rica, the two that I know, and I'm sure that there are others out there that are actively working on trying to come with an agreement between the medicinal healers and the traditional hospital setting. And the problem is the U.S. as well as some of these other locations, they don't know enough about the natural medications.
Or they choose not to know.
They choose not to know, for sure. But I remember having a conversation with a nurse in Costa Rica, and she said, I'd love to prescribe whatever it is, garlic, whatever, it's a medicine. But she said, I don't know how. Yeah. And they're trying to advocate for learning more about that and those models, or maybe integrating traditional healers into the medical landscape. So there's a way to make it work for both.
Right.
For sure, preventative medical care. I do, as a health professional, have to just say that you want to be cautious about using certain supplements and things like that. Not because they're not effective, but they can cause harm in livers and kidneys and things like that.
You have to read the side effects.
You have to read the side effects.
Yeah, and if you're already taking some Western drugs, you don't restrict with blood thinners.
Oh, absolutely.
Yeah,
that is
something then Xarelto, blood thinning medications.
And then sometimes people try to take a supplement and it counteracts, or it could increase the thinness and cause bleeding. So I'm not saying these things don't work. I'm just saying, you have to do your work. Right.
Basically.
But know the boundaries. Read what the side effects. Read what this might do. A lot of women ask me about herbal remedies for their hormones. A lot of people don't know if you have a hormonal cancer, you should not be taking those kind of natural remedies.
Estrogen things too. Also, any sort of estrogen producing type medication can affect tumors, and so they do, like you said, they do work. It's do your research, learn about them, try to find a clean manufacturer, because sometimes the filler ingredients that they put in there are, you don't know what they are, because a lot of supplements are not tested through the FDA, and you'll see a label on it that says that. So there's a place for everything and for everyone. Learning about your own herbs, growing your own herbs, and mixing it and making tinctures and things like that. There's a place for all of that. And
I just don't feel the medical industry is like I said, it's for profit, And the culture of natural remedy is
It's just not
where
where.
by word of mouth.
It's also cheaper to just to pick a plant. You know,
I think it does hurt the medical industry if all people were to go that way to some degree, you know. I think my biggest also thing is with the insurance companies, and I'm still learning all this, and so other viewers at home, is that when the insurance company, they take a while to pay out. They take a while to pay out.
Yes.
You know, I've seen people be very, very stressed behind this type of situation.
Yes.
yeah.
You know, why is that? At the end of the day, we went in for an emergency. I've been paying this copay. I've been doing my part. Who says, why is there no deadline about when they have to pay out
Yeah.
to some degree?
But I've the deadline.
Is yeah. So part of it is what I was saying earlier, where the hospital, first of all, they have to submit the bill,
Right.
right? They might send you a bill,
Oh, you're going to get
So-
that. You're gonna
but because if it's an itemized bill or something, but they have to. There are guidelines and rules and regulations around when a chart needs to be complete. It's supposed to be 30 days after the discharge, but the hospitals are not getting reimbursed. They don't have enough staff. They don't have enough skilled staff because this is totally a skill.
Okay.
And so that timeline gets pushed back a little bit. Then when someone finally actually reads it, they're like, oh, wait a minute, this needs clarification. This is not clear. Let me call the doctor. That takes time. Then the doctor has to, they can't just tell you,
Right.
oh yeah, I meant to write, no diabetes when it is diabetes,
Exactly.
They have to actually write it in the chart.
Wow.
And that might take some time. Then finally, all of that time, then they send it to the billing department, and the billing department they also have their own rules and regulations, and it might get kicked back for some reason. So that has to get resolved. By the time it gets to the insurance company,
My goodness.
it's a few months later.
And
that's the insurance.
They're taking a minute too.
They're taking a minute and they're denying it. They denied it because something was wrong. And now you have to look at it and you have to respond within a certain time. Sometimes it's 10 days, sometimes 30 days. It depends. But imagine if it's a 10-day one, you get something that comes into the hospital. If they're old school, it's going to the mail department and has to get sent to that department.
Experience.
And then you have, whichever department within the health information department is supposed to handle denials, right? And so they have to look at it and go, oh, did we do anything wrong? No, we didn't do anything wrong. Oh, no, let's give them more information that this is actually this, and this is the specific guideline that we were following, right? You have to put all that in a letter, send it back.
That's a process. And
Right.
this was somebody that's sick.
Right.
I'm saying the person.
I don't even have the mindset to do all that.
But you don't have to do it. Thank goodness you don't have to do it at that point. That's all the hospital. But in the meantime, the hospital is sending you a bill because they're saying your insurance company denied, right? Because a lot of it is automated. So like once they receive a denial, they're going to trigger a letter to you
Oh no.
saying that you owe, even though you don't, because now
You get it however they can. If you're gonna get money, put your Visa card, MasterCard, or cash, and we'll take it.
So that's why I would say read your letter first. If it says insurance denied, call your insurance company, find out why it was denied. Is it something that they didn't get? I had someone who the hospital had their old insurance card because they're working for somebody else. And 2 years later now they're working for somebody else. They have a new insurance. Even though they gave it to them, there was like a number 1 spot and a number 2 spot, and they didn't make that new insurance the number 1 spot. So they billed out the old insurance company. Of course, that person is like, this person is not covered, right? And so it's not until you, the individual, are looking at it and you go, wait a minute, they built the wrong insurance company. You got to do this whole process again. Call up the hospital. You built the wrong insurance company. This is my insurance number, and then they bill the insurance company. So you always want to scrutinize your bill, ensure that they have the right information, ensure that if you have updated insurance, that you're giving it to them, ensuring that they're deleting it. So it's all of those reasons why.
It seems like there's a lot of steps in there. I feel for the American people when they get sick and they have to go through this process. I mean, some of the stuff they do themselves, but to see those, we've been through it, honey. Seeing those medical bills pile up, and it makes
Stressful.
it's highly stressful. It creates for conversations that you don't want to have.
Makes you want to rob a bank.
Yeah, they a whole another problem. So we have to close up in a second, but I'm gonna ask you. You are a healthcare professional insider to some degree. Tell us before you go a couple of things to the Live Well audience of things that you've actually witnessed and seen that you wish would just completely change. It just makes no sense.
For home care, especially, we need more education in home care, especially for patients that are newly diagnosed. So there needs to be reform in the home care aspect of it. In terms of like someone with new diabetes, new hypertension, they do give a little bit of education in the hospital, but you're so overwhelmed by whatever just happened to you.
Right.
And, the nurse or whoever the practitioner is going to say, okay, you were diagnosed with hypertension. They put you on this new medication.
Right.
Make sure you watch your salt intake, and, you should exercise. And you get home and you're just like, whatever mess you left before you went into the hospital, your house is in disarray.
Yeah.
You have to figure that out. And then you're like, what medication? They didn't give you the medication before you left. And then you're like, what did she say I'm not supposed to take? Would not take this you need to have someone that you can call to help guide. And that's that health literacy advocacy portion that I was saying about. But I see a lot of patients get in to their home and they've forgotten all the information that we've given them about the medication.
Right.
They're taking it at the wrong times, so it's not effective.
Okay.
So they just think, well, I take it with all the other pills. Oh, whatever, Diabetes, they are unaware of how to check their blood sugar, how often they should be doing that, what time they should be doing that. So that's something it really bothers me. The other thing within healthcare as well is, with our elderly population especially, is not taking a holistic approach.
Yeah.
A lot of times we treat the disease and not the person.
Yeah.
Okay.
And so, this person just came out, they have diabetes, so okay, we're only going to talk about diabetes. And it's like, I used to have patients. I had a blind patient who her kids used to just sit her in front of the TV, turn it on. She never knew what station it was. She never knew what she was listening to. And she was like, I don't know, all this noise all the time. And I'm like, how are you coping and being home, whatever? She's like, I really miss my music. And, that was a simple fix to say, you should put on music. I had another patient that he was also legally blind, but he could, see shapes and things. He was able to cook his, I used to be so surprised he could cook his eggs in the water, but he used to cook, but he also, was bored. He was like, I'm in here all day. Nobody comes to visit me. I get, gets one visitor, maybe a week. And I don't know what to do. And I said, well, what do you like doing? He's like, well, I used to read before I was blind, and he used to travel and things like that. So people don't know this, or may not know this, but in New York City, the public library has a mail-in library program. So if you can get your doctor, you get the form from them, and your provider office can just say, yes, this person is blind, they need assistance. And they can have books, CDs, DVDs, whatever it is, audiobooks.
Yeah.
Right.
Even books if they're homebound.
Yeah. Okay.
If they're homebound, they can have regular books as well, be mailed to them. You need somebody obviously to mail it back, but you pick out the genres that you like, and they'll send you the books, and you just have somebody send them back. And I set him up with that, and every time I went to visit him, he had an argument for me about what he heard on the audio book, and they said this about, he liked history, and this was wrong, and
Oh my goodness. If you try to help
definitely, but it was stimulating, as she said. And so I think those are a couple of things that I saw that could be improved, that I saw was sad that we sort of put people out to pasture, either when they're discharged from the hospital, they're not getting enough interaction, education around their new disease process. That hypertension patient, whole cabinet filled with canned goods, while that's economical, and for some, you still need to educate about the portion size, and going through, and the hospital, they don't have the time to go through all of that. So we need more. We need more of that, the holistic approach.
Right.
Because that's bothersome, and I think people meet their demise much sooner than if they were engaged.
Like you said, they treat the disease, not the person.
Correct.
And I totally agree with you. I went through bouts of depression. Even though my wife was there loving, she was supporting me, it was still it was a lack of education. I wasn't getting understanding. I didn't have community. I didn't have a support system outside of that of my wife. Be able to even educate her about what was going on. All I was going through, what I was going through, and I thought nobody else cared to some degree. It was a dark time, but we was able to get out of that.
Yeah.
We was able to find.
We're just not going to get sick.
Right, and now it's just the goal is to live well, and not be sick. Just for him to show it. I just want to thank you guys for watching today. Ayana Culley, she was awesome. Sorry I heard back and anything. You were really wonderful. Next time, we do want to hear like the little Edward Snowden, deep little tidbits of espionage is going on.
You come back, we're going to go deeper.
We don't. It's gonna happen. It's coming. It's yeah, sure.
I'll be back and everything. But again, thank you so much, and thank you for having us and all of America for what you are doing in the healthcare and being an advocate and supporting us. So people like you, we need more people like you at the end of the day. That's it. Okay. Yeah. So this is Marcello Thedford, and I'm here with my co-host Trina McGee, my wife, and we tell you every day it's just good, healthy talk. And remember, live well.
Live well.